Okay, so today what I'm going to be talking about is an NG tube, which is a nasogastric tube. So the reason it's called that is because it's inserted into the nares. And then just so you can see here, the tip of the tube should actually be sitting in the patient's stomach. So when we are checking for placement, and I'll talk about that in a little bit, that's what we're making sure of, is the tip of the tube is in the stomach. Just kind of gives you a visual here. All right, so this is a lot of information about NG tubes, and you're getting everything with this except NG tube insertion, which you will get in 151, so next mini-mester, okay? So this is everything else that goes along with the NG tube other than the insertion. We tried to split this up into two different validations to help it make a little more sense for you. There are several reasons why you would have an NG tube, okay? Either you have the tube in because they have it hooked up to suction and they're trying to keep your stomach empty or decompress it, okay? This is maybe pre-op, post-op, trying to let your stomach rest. They're trying to get rid of your stomach contents, okay, and keep it empty for you, okay? So that's one reason why you might have an NG tube in. The other reason might be for nutritional support. So you're actually getting feedings and medications through the NG tube, okay? So they don't go together. It wouldn't make sense to have an NG tube down, have it hooked up to suction, and also getting feedings, okay? So there are two separate reasons why you would have the nasogastric tube. I do have a couple different ones to show you here. This is a Salem sump tube. This is typically what you have in if you have the NG tube inserted and it's hooked up to the suction, okay? If you'll notice, there's a blue side tube here, and that is just simply to vent the tube so it doesn't adhere to like the lining of your stomach, okay? So this is typically what you have if you have the tube for suction. The other tubes I have here are for feeding tubes, okay, which you may see. This is a Levin tube. That's a common feeding tube, and this one is called a Dubhoff tube, which can actually sit in your stomach or the small intestine, the tip of it, okay? And if you'll notice, these tubes are very small, so the thing about this is they're very easy to clog, okay? So that's why we're going to be flushing before meds, flushing after meds, flushing before and after feeding. You're trying to keep things moving along so you don't clog one of these very small feeding tubes. The other thing I have here, I don't know if you guys have worked with G tubes or PEG tubes, a gastrostomy tube, or a percutaneous endoscopic gastrostomy tube, okay? A lot of the same things you'll be doing with those that you're doing with NG tubes, except they are not inserted into the patient's nose. They're actually placed, they go right through the skin, right into the patient's stomach, okay? That would be more for long-term nutritional support, and the NG tube would be more for short-term use for feedings. So those are just a couple of examples. Okay. I talked a little bit about the Salem sump tube. So first we're going to talk about having the NG tube down and the patient has it hooked up to suction. Okay. The one thing about these tubes is you try to keep this blue vent tube above the patient's head. If you let it hang down like this, what's going to happen is some of the stomach contents is going to start to leak out of this blue pigtail. For that reason, you may see these anti-reflux valves on the end of there. Okay, it just kind of prevents that from happening. But again, you do try to keep it higher than the patient's head. If they are not being used, you know, they might just have it capped off with something like this then, okay? So the other thing you want to keep in mind with the NG tube is the patient is doing a lot of mouth breathing, so you want to make sure that you're doing frequent oral care, okay, and putting some lubrication on their lips, maybe checking the nares, making sure, checking for any breakdown around the nares, okay, you can even put some lubrication around the nares as well, okay. The other thing with this blue vent tube is you would never put anything through it except maybe a little bit of air to clear it, okay? So if you have a patient that is going to be hooked up to suction, you would have to have an MD order to do that. Usually the order is for suction to low intermittent. If that's the case, whenever you're hooking up turning the suction on at the wall, you're turning it to less than 80, okay, to adjust it. The other order may be for high continuous. That typically you don't see, except you might see maybe in cases of poisoning, or if they're trying to empty the stomach contents from medications or for poisoning, something like that. But mostly what you're going to see is low intermittent. You will have a doctor's order for that, okay? So you're going to check the doctor's order. You would come into the patient's room, of course identify yourself, let them know what you're going to be doing. First thing that you would want to do is do a focused abdominal assessment. Have you guys had that in your assessment class yet? So patient would be more flat for this, but I have them elevated so you can see what we're doing. First you're looking for any abdominal distension, okay? Then I would be listening in all 4 quadrants, listening for bowel sounds. Might not have any bowel sounds or very hypoactive bowel sounds, and that's why the patient is going to be hooked up to suction. And then the last thing you would do would be to palpate and feel for any pain, any tenderness, okay? So you're doing your focused abdominal assessment. The other thing is I do want to just take a peek here at the tape on the nose. I can see that it's coming loose, so the first thing you need to know how to do is how to tape one of these NG tubes. Sometimes in clinical they may have the little prepared holders that you'll see on the nose. We just have tape here, so I'm going to rip one piece of tape down the middle like this. Get that ready, and it's better to do this without gloves. The other one is just another little piece of tape. I'm going to put my gloves on anytime I'm working with one of these tubes. You can see it's already secured here as well, again, just to keep from pulling it out. I'm going to loosen this tape that's coming off. I don't want to let go of that at all, so that's why I had my tape ripped and ready to go. I'm going to put that part on the patient's nose, and these 2 pigtails I'm just going to wrap around the NG tube like that to hold it, and then the other piece of tape is just going to go over the bridge of the nose. Okay, so I want to make sure that tape is in place and secured so that NG tube doesn't end up backing itself out of position. Okay, again, I would make sure I'm doing good oral hygiene. Patient would be on intake and output if they have an NG tube. And again, just checking the nares, making sure that the tape is all secured. The other thing with an NG tube is you never want to put anything through the NG tube without first checking placement. Okay? These tubes can come out of position, so the tip is no longer in the stomach. Now the tip is sitting in the patient's lung, and you've dumped normal saline or water or feeding into that tube and into the patient's lung. So first thing you need to do is confirm placement. make sure the tip of that tube is sitting in the patient's stomach. Okay? There are several ways to do this. Okay? Initially, whenever the tube is placed, it is confirmed by X-ray. That's obviously the most reliable, but you can't be getting an X-ray every time you want to use the tube. Okay? The other thing you can do is check the pH of the aspirate, and I'm going to be talking about these in a little bit. Your Taylor book says less than 5.5, okay? Usually stomach contents is acetic, okay? So it's usually going to be less than 5.5, less than 4 is what some other books say. You're also going to be assessing the aspirate for the color. You can measure the tube, check the marking, and then there's also auscultation, which again your book says is an unreliable method, but you're going to be seeing that at the bedside in clinical. Okay, so I will show you these, and just keep in mind that you're not using any one method by itself. You should be using several in conjunction, so you're looking at several things together to confirm the tube placement. Okay, so first of all, if you're going to check the pH, this is one way to confirm placement. You would just be hooking up your syringe, pulling back a small amount of aspirate, and you could just be possibly putting that into a little medicine cup. Okay, and then I have these pH test strips. Okay, it shows you color code, checking the pH, and again, you want it to be acetic, less than the 5.5, to confirm that the tube is in the stomach. Okay, if it would be greater, like 6 or 7, it might be in the lung, might be in the intestine. Okay, so that's one way, is to check the pH. The other thing you can do is, you know, when I pulled some of that out, the aspirate, I'm checking the color of it, okay, to make sure what that looks like. Usually if it's gastric, it might be green with little flecks in. It might be brown, which might be some indication that there's some old blood in there. It might be an off-white color, okay? So you're looking at the color of the aspirate in conjunction with the pH, okay? What's the other thing? Measure. You can measure to confirm placement. Your book talks about actually measuring the exposed length of the tube and comparing that with the previous note. Most of the new tubes have little markings on here, so you can just note the number at the nares and make sure again that the number is the same as what was documented and the tube is not working its way out of position. Okay? Or the nurse may make a little black note on the tube as well. Okay, so that's another way you can check. This is what you're going to see at the bedside, because I don't think usually they have these pH test strips. You can pull back about 20 to 30 milliliters of air, and you're going to hook this up to your NG tube. You're going to listen over the left epigastric area. You're going to push this air in very quickly, and you should hear that little whoosh of air with your stethoscope over the stomach. Okay, so again, your book says not to use that, because sometimes if that tube is sitting in the lung, you still may hear that little puff of air. Okay, but if you use that in conjunction with some other things, like checking the color of the secretions, okay, then again, I think that is a lot of times what you're going to be seeing at the bedside. Okay? All right. So again, I've done my abdominal assessment, I've confirmed my placement, making sure that the tube is in the correct position. Once I've confirmed placement, I do have an order to hook up to low intermittent suction. So again, turn your suction on at the wall. You would want it to be less than your 80. You'd want to check your suction first, like any equipment, before you apply it to your patient, and then hook up your suction. Okay. You may also see these little stopcocks on a lot of the suction canisters. One of the positions says off, and that just needs to be to the section that you're not using. Okay. Once you hook this up, you're likely going to see a lot of stomach contents pouring out into the canister here. Okay. And just take a minute to look at this. One of these tubes has to go to patient. One of these tubes has to go to the vacuum. Okay. Typically then at the end of your shift, when you're recording intake and output, you will just mark on here with a pen the time and your initials. Okay. Once this canister is full, they usually put the powder in here to kind of solidify it, and then this whole thing would just go in the biohazard. Okay? So that is the suction. Oftentimes when patients are hooked up to suction, okay, and the low intermittent just means that it's continually cycling on and off. A lot of times what happens is it's pulling a lot of thick stomach contents out, and these tubes get blocked. You should have an order to irrigate the tube, PRN or as needed, just so you can relieve that blockage. If that's the case, turn the suction off, disconnect. Again, you want to make sure you confirm placement, because I'm going to be putting something in this tube. So I've checked placement. I'm just going to draw up, your book says 20 milliliters of normal saline. And what you're going to do is just irrigate the tube with 20 milliliters of normal saline, just to try to relieve any blockage that's in there. Hopefully, once you've done that and you turn your suction back on and hook it up, you're going to see stuff pouring back out of that tube and into the canister. Okay? You shouldn't be forcing anything when you irrigate. If you try to irrigate and can't get anything through, you can just try putting a little bit of air in there again. Maybe it's in a position like up against the wall of the stomach, okay? But hopefully that would be enough then to relieve it, and then your tube starts functioning again. Okay? So that is pretty much everything that goes along with the suctioning, okay? Again, the other reason to have an NG tube would be for nutritional support. You can feed a patient either continuous with the pump, or you can feed the patient boluses with the syringe, and that would be more of like an intermittent type feeding. Okay? Anytime the patient is receiving a feeding through an NG tube, they're at risk for aspiration. So for that reason, you want to try to have the patient sitting upright at least 30 to 45 degrees, and then you would be assessing your patient for signs and symptoms of aspiration. Okay? To check to see how your patient is tolerating the feeding, you should be assessing your patient for nausea and vomiting, diarrhea. Again, you would be checking bowel sounds when you're doing your assessment, any abdominal pain, distension. Okay, you would be checking all these things to make sure your patient is tolerating. Okay, so again, if you're going to be doing this, you would need a doctor's order. Okay, and I would come in with my doctor's order. We'll talk about the pump first. So I have an order for Ensure via the NG tube at 75 milliliters per hour. Okay, so there's my doctor's order. A lot of times feeding will come like this. You've probably also seen like the cans of Ensure. Okay, so you're just confirming that against your doctor's order. Again, you should be doing your 2 checks before you even get into the bedside. You're trying to be as aseptic with this as you can. I know your book talks about even the cans of Ensure. You should be like wiping the tops of those with alcohol, wearing gloves, and just trying to be as clean as possible with that. Feeding should be room temperature. Okay, you don't want to be dumping anything cold in there, which would cause cramping. You're also checking expiration dates of your feeding and making sure that that's all good. So again, you would come in the room with your equipment, do all of your assessments, your focused abdominal assessment. Okay. The other thing I want to check before I put feeding through that tube is confirming placement with one or several of those methods that we talked about, making sure that tube's in the right place. The other thing that you need to do before you give a tube feeding, checking for placement, also checking for residual. Okay, so to check for residual, this patient would not be hooked up to suction. This is a different patient. So once you've confirmed placement, the other thing I need to do is check for residual. Hooking up my syringe here, and what I'm trying to do is just pull all of the stomach contents out of the patient's stomach, and I'm going to measure that in my graduate. Okay, so I'm just simply pulling this, and I'm just going to keep putting it in my graduate until I can't pull back any more stomach contents. Okay, so I have all my stomach contents there, and then I'm just going to measure to see what my residual is. Okay, depending on the physician's order or your policy at your facility, your book talks about the number 200 milliliters. If you would get something greater than 200 milliliters, you would be holding the tube feeding. Okay, so you want to make sure what you're putting into the patient's stomach is being digested, and you're not just dumping more food in and it's just sitting there. Okay, so if the patient is on tube feedings, you're going to be checking, like continuous tube feedings, you're going to be checking placement every 4 to 6 hours and residuals every 4 to 6 hours to make sure the patient is actually digesting the food that you're putting in there. Okay? So for our purposes in here, we're going to go with 200 milliliters. If I would pull out more than 200 milliliters, I'm going to withhold the tube feeding, and then you would possibly be going back in a couple hours, checking again to see if you would get something less than that, and then you could proceed. Okay? I think probably too it depends on the policy at the facility, but typically if it would be less than 200 residual, then you would be putting it back into the patient's stomach. Okay? So the other thing I want to talk about is flushing. Alex is making a face. Okay. This is undigested food that's giving your patient nutrition, electrolytes, hydration. I don't necessarily want to withhold it from him if he's digesting it. I'm just trying to make sure that I'm not just dumping it in, dumping more in, and it's just sitting there. Okay? So if it's less than my 200, I am going to give it back. Okay? And then I would proceed with my tube feeding. Okay? The other thing I want to talk about is flushing. And again, flushing is just that in-between step to keep things moving along. Okay? So what I can do is just kink this tube, and I'm just going to use my irrigation set here, probably just maybe 20 to 30 milliliters I'm just going to flush this with some water, and that just is by gravity. Okay. I'm just clearing the tube once I've checked the residual. I'm going to clamp it and lower it. I am going to give my residual back. We'll say I only got 100. Again, it just flows in by gravity. I'm not forcing it in with the syringe. And then again, that in-between step to keep things moving, keep my tube from clogging, is just flushing again with another 20 to 30 milliliters of water and letting it run in by gravity. Okay. Once I've checked residual, flushed, given the residual back, and flushed again, then I'm ready to proceed with my tube feeding. Okay. So the first way we're going to talk about is the continuous tube feeding. I have 2 of these kangaroo pumps. Okay. Again, you would be getting, you know, your bag. There's a label in here. Checking your doctor's order. Okay. These bags, I think, are typically good for 24 hours. Okay. And I don't think you want to let feeding sitting in this bag for more than 8 hours because bacteria will grow. Okay. And then the actual system's changed every 24. So I've checked my doctor's order, I've labeled my bag. We're just pretending this is the feeding I'm to give Ensure. I'm going to make sure I clamp this off just like I would my IV tubing. I'm going to check this against my doctor's order, check the expiration, make sure it's room temperature. I've shaken it up, and I would just pour this into my bag. I want to make sure I prime my tubing. It just looks like an IV roller clamp. I'm going to open that up, get all the air out of my tubing. Air is not going to hurt the patient, but it's just going to, if you keep introducing more air, their stomach's just going to get being more distended. Okay, so you're trying to limit that. Okay. I'm going to go ahead, turn my pump on. And just kind of practice feeding this through here and setting the pump. Again, my doctor's order was for 75 milliliters per hour. So what I'm going to hit here is, well, the rate is whatever is blinking on here. Okay, so whatever is blinking is my rate. There's a dial on the side. I can just dial that up to my rate, which was 75 milliliters per hour. The other thing I need to set on here is volume to be delivered. Okay, again, similar to your IV pump. What I have in here is 250, okay? And the only thing, again, you need to be careful about this is I'm not dumping, like I wouldn't want to dump this clear to the top with feeding if it's only running at 75 milliliters per hour. I want to make sure it's going to empty within my 8 hours so it's not just sitting there, okay? So I have 250 in here. I'm going to set volume to be delivered to 200 just so I have enough time to go and get more feeding if I need to. And again, whatever's blinking is my rate. I would hook this up into here, and once I get untangled, I would just hit start after my clamp's open. Okay. So again, with patients on a continuous tube feeding, I'm still checking, confirming tube placement every 4 to 6 hours. I'm still checking residuals every 4 to 6 hours. Patients in an upright position because they're at risk for aspiration, so I'm assessing them for signs and symptoms of aspiration. Just making sure they're tolerating this, they're not having nausea, vomiting, diarrhea, constipation, okay? And again, if you continue to check those residuals and you're getting too high of a number, then the order may need to be changed, maybe to a lesser rate or lesser amount of feeding. Okay? So that would be a continuous tube feeding with the pump. I do have 2 of these kangaroo pumps, so do take a minute just to kind of learn how to use those. Okay. The other way that you may need to feed a patient would be more of an intermittent feeding, and this would be like a bolus feeding. So again, you're doing the same steps as far as your assessment, confirming placement, checking for residual, but I have an order here to give Ensure 40 milliliters every 3 hours, okay? So once I've checked the residual, I've flushed, I've given the residual back and flushed again, okay? You can do this one of 2 ways. You could either, if this were my Ensure, I could either measure this out into something, my 40 milliliters, or I can look at my tube here and kink my tube off and deliver my 40 milliliters right into here. Okay, and this just simply runs in by gravity. Okay, so if patient complains of cramping, you can just kind of slow down, speed up, okay, and it's just running in by gravity. You can actually put fluids in these mannequins. They have little stomachs in here. Just try to every once in a while then hook it up to suction so it pulls it back out, okay. So once that's delivered, then the other thing I want to do is just flush. Again, 20 to 30 milliliters of water to make sure that I clear all the feeding from that tube and I'm not clogging that tube. Okay, so again, by gravity, I'm just letting my flush run through the tube then. Okay, so those are the 2 different ways you can do a tube feeding, either continuous with the bag or the bolus with the syringe. Okay. The other thing I want to talk about is medications. This goes in. To give medications through the NG tube, again, you still need to do those initial steps of assessment, checking for placement, and you also need to check residual with meds. I want to make sure what medications I'm dumping in there are being absorbed, okay? So checking placement, checking residual. With medications, what can be switched to liquid hopefully is, because that's easier to administer through the NG tube. The other things you can give through the NG tube are tablets, which you would have to crush, okay? Some capsules can actually be opened up, okay, and mixed with water and given like that, but you do need to check with your pharmacist. Things that you can't are enteric coated, time released. You certainly can't crush any of those. Sublingual meds, buccal meds, okay. So typically just tablets and some capsules with the little like pellets in can be administered that way, okay. Again, patient's head is elevated. If they are hooked up to suction and they have to get meds in between, you just want to make sure that you keep the suction off for 30 minutes after you administer the meds, so you're not just taking them back again, okay? So the other thing you may have to do is give some medications. Again, we'll have a MAR for you, okay? If you do need to give meds, you'll start at the MAR, at the med cart. you will do your 2 checks out here. If you need to crush medications, usually if it's a tablet, you'll put it in between the 2 cups and you will crush your med, okay? And then what you can do is put your med into one of these liquid cups, and then you want to add 30 milliliters of water, warm water, and then just make sure it's well dissolved before you would give it to your patient, okay? You want to give one at a time, okay? So if I have 2 medications to give, 2 tablets, I would crush both tablets. I would put both tablets in 30 milliliters of water until they dissolve, okay? And then to administer these, again, you know, you'd have to make sure you've done your appropriate assessments. If it's DIDs, you're checking a heart rate, that type of thing, okay? But then to give the meds, you're giving them one at a time by gravity. First medication. I think my stomach's getting full. Okay. So, first medication by gravity. Again, if you can just, you're going to have to keep track of all this for your I&O, so if you kind of know what you started with in here, this is marked off, and then again, just make sure you're recording, you know, the 30 that I mixed with my meds, my flushes. You're going to have to keep track of all that. So med ran in, I'm going to do my 20 to 30 of flush, let it run in. Once it's all in, I'm going to give my second medication, let it run in by gravity, and then I'm going to follow with my flush again, 20 to 30, just to make sure things are moving along and my tube is not clogging. Okay? So that's the medications. Okay. It's going. Okay. I think the last thing we need to talk about is discontinuing the NG tube. Okay. You would need a doctor's order to discontinue the NG tube. Okay. So I checked my doctor's order. Again, let the patient know what I'm going to be doing. Certainly not as uncomfortable as having one inserted. They're usually very happy to be getting this tube out of their nose. I have my gloves on. Going to just put a towel across the patient's chest. Again, patient's in a more upright position. Can do my focused abdominal assessment. Again, hopefully the patient has some bowel sounds if they were hooked up to suction, and I'm taking this NG tube out now. Disconnect anything like suction or the feedings or anything that was hooked up to it. Your book says to check for placement. Doesn't make a whole lot of sense because it's coming out, so you can forego that step. What I am going to do is just inject 20 to 30 milliliters of just air this time. I want to make sure if anything is in that tube, when I go to discontinue it, it's not going to be dripping back down the patient's throat. So I'm going to just clear it with 30 milliliters of air. I'm going to unpin it from the gown. I'm going to give the patient a basin just in case they get sick as I'm pulling it, and I'm going to loosen my tape here. I'm going to kink the tube off, again for the same reason, trying to keep things from dripping down the patient's throat. Ask the patient to take a nice deep breath, hold the breath, and then you're just going to be smoothly pulling that out. Check the tip, make sure the tip is intact, okay? And then you could just wrap it in your chucks and it would get thrown away. Offer the patient some mouth care just to help with that. And then you're going to be assessing your patient. making sure they're not getting distended, they're not having nausea or vomiting, any signs that might make you think the NG tube needs to be reinserted. Okay? So again, I think I covered both of these things, either suctioning or the meds. There are actually 5 of these mannequins. When you are ready to practice, there's bins on the bottom of the cart, there's mannequins there, you can just kind of set up a bed station and practice all these skills. It's a lot, but if you break it into those 2 separate things, it seems to make a little more sense. And then in 151, you'll get the NG insertion. Any questions, or you want to add anything, Arlette?
If they have a, like, insured, and you're gonna, do they have like a requirement for a water intake tube that you would have to add in addition to the flush?
I think a lot of times they do,
Usually-
before and after.
In the hospital setting, at any rate, whenever you have anybody on a tube feeding, they automatically have a registered dietitian following them, and they make recommendations for water as well, because the formula doesn't supply all the water that you need in one day. If you're looking at just going to an Ensure diet, you still need additional water, and they usually recommend whatever feeding plus 250 of water every shift, or whatever they need for additional water.
Are you using tap water or sterile water or?
Tap water is typically what we did. For a while we did sterile water, but what we eat is not sterile. So they went back to just tap water, and sometimes they recommend normal saline if there's a sodium imbalance. I typically just see people using tap water.
I know your book mentioned normal saline with flushing, but that we always use water.
We always would.
Yeah.
And the other part about the refeeding, in higher amounts, when you're pulling out or have higher residuals, you're actually pulling out electrolytes, and you can alter a patient's pH balance, because if you pull out too many electrolytes, just like when you have nausea, vomiting, and diarrhea, as you're vomiting electrolytes and all that acidic, you can actually change a patient's electrolyte balance internally by pulling out too much of their positive electrolytes, their acidic stuff. So the recommendation is to refeed. Honestly, often you don't get any more than 40 to 60 of residual. It's rare that you're getting that much back. And I usually don't have to dump it in a bucket. I can just pull it up in this syringe. Oh, there's 60 there, and I just push it right back in.
The temperature that you would use for the water, does it?
I don't use hot or cold. I try and go with room temperature, or stick my hand. I don't want to use real hot or real cold.
I noticed that you didn't flush before the first medication, or we're not flushing prior to the first med.
You would when you're doing your focused assessment, you would be flushing?
Okay, so that counts as the first flush
Yes,
before the med.
yes.
Right, again, remember, I checked residual, and then I gave the residual back. So that flushing is just like the in-between step to try to keep things moving. So
Okay, I
it
wasn't
can't
sure.
hurt anything to flush it, just to kind of clear that tube, and because that's the last thing you want is a blocked tube, and then you have all kinds of issues.
And sometimes with an NG, depending on the size, how big the diameter is, you can't run gravity. And sometimes you have to pull it up in the piston syringe and push it in. You're still going to do all the steps. The only difference is you may not be able to do it gravity. I always attempt gravity first, depending, because you can get smaller NG tubes and then things don't run through them as well. Or depending on where they're positioned in the stomach, you may have to almost piston syringe push it in. But the goal is to do it by gravity, and that is always the first attempt.
Okay. Go forth and practice NG tubes.